Hello friends, I am Dr. Krishna Prasad, Senior Cardiac Surgeon, Medicover Hospitals. In this video, I would like to talk about valvular problems of heart disease and explain what these problems are, what treatment options we have got, and how to go about deciding what treatment is good for you. First of all, let us understand what these heart valves are. Many people actually confuse coronary arteries with valves. They go about saying, I have got 3 valves blocked in my heart and things like that. Coronary arteries are the arteries that are there on the surface of the heart, whereas valves are inside the heart, inside the chambers of the heart. Most of us know heart has got 4 chambers, that is 4 rooms. The right-sided 2 chambers deal with the impure blood and they pump the blood to the lungs. The left side 2 chambers pump the blood to pure blood to the rest of the body. And at each point there is a valve. And these valves are principally placed in such a way that blood does not go back. Now, if you understand, circulation is a closed system. It is like our water pipe system, where water is being pumped from the water station and it is being received at our end. But in circulation, it is just going round and round inside our body. So the heart is the pump that is pumping the blood, but we don't want the blood to go backwards and forwards. So if these valves were not there, each time the heart is pumping, most of it would go back and then it will be coming forward. So there will be no forward blood flow, and that's the reason why these valves are there. Now there are 4 important valves in the heart. And the right side ones are called tricuspid valve and pulmonary valve, and the left sided valves are called mitral valve and aortic valve. So these names suggest how the valves look like, their appearance, and usually it is derived from a Greek name. So let us not get it much into the details of why these valves are called the way they are. What we need to know is what can happen to these valves that can cause problems. There are 2 kinds of problems that can happen with valves. One is they can become narrowed, so that the area that is available for the blood to go through will become small. The other one is when the doors are not functioning alright and the blood is leaking back. So the valve narrowing lesions are called stenosis. Again, it's a Latin word for narrowing. And lesions or the problems where the valve is leaking back, they are called regurgitations. It is just like we get sour regurgitation or anything that is coming back is called regurgitation. So these are the 2 types of problems that can arise in the valves. Depending on which valve is involved, suppose mitral valve has got narrowed, then we call it as mitral stenosis. And say if mitral valve is leaking, then we call it as mitral regurgitation. Same thing with aortic valve. If aortic valve is narrowed, then aortic stenosis. And if aortic valve is leaking back, then it is called aortic regurgitation. We should understand that based on the position where they are, if any of these problems comes, either narrowing or leaking back comes, the chamber before the valve will start experiencing higher pressures than what it is usually used to, and that will lead to the problems or what we call as symptoms. Most common valves that are damaged, if you take across all the heart lesions, are on the left side. We principally think that is because left-sided chambers deal with higher pressures, so those valves are more possible for them to get damaged, and so left-sided lesions are most common, of which mitral stenosis, mitral regurgitation, aortic stenosis and aortic regurgitation are common in our country. We'll come to the causes why these valves get damaged a little bit later, but we will just understand what happens when these valves become damaged. So when mitral valve or aortic valve gets damaged, either it gets narrowed or when the valve is leaking back, the chambers before them, that is the left upper chamber, will start experiencing higher pressures. And there are no valves between that and the lungs. And so the pressure will be transmitted back to the lungs, and the higher pressures in the lungs will make a patient become short of breath. When we call shortness of breath, Suppose you are used to walking 1 kilometer every day, but once this problem starts and it starts becoming significant, walking that 1 kilometer will be very difficult. Even after walking 3/4 of a kilometer, you are huffing and puffing like this. So if that is happening from what you are already used to activity, that is the beginning of it. As the disease progresses, the distance at which you get shortness of breath becomes lesser and lesser. So when we say grade 3, then it is just walking 50 yards or 100 yards will bring the shortness of breath. And kind of the last stage is when while you are sitting also, if you are short of breath, that means the valve has become really, really bad. Fortunately, with current medical techniques and availability of expert doctors in most remote areas as well, picking up these problems is happening at an earlier stage. So it is not as bad as what we used to see some 20-30 years back. And late presentations of grade 3 and grade 4 are very rare, but still we see some cases which come in extreme situations from very backward rural areas. So what you need to keep an eye is how your symptoms are progressing. What is the usual activity that you are used to, and what is bringing, how far you can walk before you get short of breath. The other symptom that can happen with valve problems is palpitations. The heart rate can go very fast, it can go irregular. Normally, we all know, famously heart sounds are called lub dub. So, it goes with a proper rhythm, lub dub, lub dub, lub dub, lub dub. But when the heart valve problem increases, the chamber size increases, what happens is the heart rate goes fast and it can become irregular. So it can suddenly go, stop, like that. It can become a really irregular heart rhythm, and this is called atrial fibrillation. When this is one of the side effects of the pressures in the chamber becoming high. This, in an ideal world, we should be able to treat the valve problem before this palpitations come along. Very rarely people might experience chest pain, but again that is a rare part, and only chest pain with a problem happens if there is a concomitant. That means there is also an additional problem of blood vessels supplying the heart. If they are getting blocked, then only chest pain like angina can happen. Otherwise, usually valvular heart disease does not cause angina. Now, there are two age groups that are usually affected with valve problems. One is the younger age group between 20 and 40 years. The other is the elderly age group, which is 50 to 70 years. The 50 to 70 years age group patients, they usually have problems because of aging. As we age, just like our hair becomes white and our skin gets wrinkles, the valves also develop problems and they stop functioning as well as they should be doing. And so from 50 to 60 years, the valve slowly degenerates, and hence this is called as a degenerative valvular heart disease. Whereas in our country, unfortunately, because of the low socioeconomic conditions in villages and people living in crowded atmospheres, there is one more condition called rheumatic heart disease that is very common. Rheumatic heart disease starts as a sore throat as in children aged between 5 to 10 years. When the sore throat comes, at the same time they have fever and joint pains. The joint pains are called fleeting joint pains. So one day they are in the knees, the other day they are in the elbows, the other day they are in the wrists. So they keep changing positions and they don't stay in one place. And when this happens, we should suspect rheumatic fever. Rheumatic fever is a very bad disease because when it comes, it only comes with the joints and as a sore throat. But 10-15 years later, it manifests as a rheumatic heart disease. So the famous saying in medical terminology is rheumatic fever licks the joint but bites the heart, because it causes the long-term damage of how it kind of damages the valvular structure, makes them very thick and non-functional, and can contribute to problems. This is again to a certain extent common in young girls, So you can imagine a young girl who would have had a sore throat at the age of 10, and 15 years later at the age of 25, when they're getting married or having children, then they will end up having heart problems which will complicate their pregnancies, and all kinds of problems arise at the time, both social, economic and clinical. But that's a different topic. So these are the two common reasons. But apart from these, there are multiple other reasons. People are born with these valvular defects. There are multiple other diseases like infections on the valves that can cause problems. Or in drug abuse patients, they can cause infections because of multiple injections they take. So there are a multitude of diseases that can cause valvular problems, but principally these are the reasons why valves get damaged. Now, once we suspect that there is a valvular damage, what tests we should do? Usually, the common tests that we do are ECG, 2D echo. And 2D echo is a very important test because 2D echo kind of gives us a visual image of how bad the valve is damaged, what are the problems that damage is causing in the chambers before, after, and overall on the heart and person. So 2D echo forms a very important modality of investigation. And other blood tests are done, but they don't usually contribute much to the diagnosis and the treatment part of it. But we need to do them before we decide on a patient whether they need surgery or not. The other test we can commonly do is what is called as a transesophageal echocardiogram, or TEE, where they put a camera down the throat and then go close to the heart and see how the valve is damaged, so we can get better images of how the valve is functioning, where the problem is, and whether it can be repaired or replaced. So these are the common investigations that we do. And whenever a surgery is decided, and for patients who are more than 35-40 years of age, we may have to do an angiogram to see if there are any blocks in the blood vessels supplying the heart. But that's a routine test. It's a discretion of your surgeon and your cardiologist. Now, once we know that there is a valvular problem, what are the treatment options? First, let us talk about narrowing of the valve. Now, in the past, till heart surgery became really sophisticated and we had good solutions, the common surgery that used to happen is called as a closed mitral valvotomy, wherein surgeon used to go in, put a finger inside the heart, and then just use an instrument to open the valve, kind of cut it open, and then it just is blown out so that the narrowing is reduced. Nowadays we don't do it through surgery, but cardiologists do it using a balloon. So this is called as a balloon mitral valvotomy, wherein they pass a balloon through one of the blood vessels, so it goes into the narrow part, and then they send it there and then inflate the balloon to make it big. So, but this is not possible for every patient, and probably when the narrowing is in the mitral position, sometimes in the aortic position, this can be done, particularly in children and young patients. Maybe it can be repeated once or twice, but if the problem is coming back again and again, then surgery will be the best option. In surgery again, we have two options. One is valve repair and another is a valve replacement. First, let's talk about valve repair. Most common valve that is repaired across the world is called a mitral valve. And based on the problem which is causing the mitral valvular lesion, there are different repair techniques that have been standardized. And using these standardized repair techniques, we should be able to repair most of the valves, 80 to 90% of the valves. But sometimes if the valve is completely damaged and if it is beyond repair, then we may have to replace it with an artificial valve. Now, valve repair, the best possibility is for another problem called as a myxomatous mitral disease, wherein the valve has become thin and it has lost its strength. Whereas very few surgeons can actually repair for the rheumatic heart disease that we have talked about earlier, because the valve becomes thickened and shortened, so the valvular repair is much more challenging. So very few surgeons repair for that condition, and most of the times when the valve is affected by rheumatic heart disease, surgeons end up replacing it with the artificial valve. When it comes to replacement of the valve, we need to understand there are two types of valves that are available, artificial valves that are available in the current medical field. One is called as a mechanical valve, and or we also call it a metallic valve. The other is a biological valve. Let's talk about the mechanical valve. The mechanical valve, although we call it mechanical or metallic valve, is not actually made of metal. It is made up of a carbon alloy. Carbon alloy is a very strong material that is used in cars or in rockets and satellite materials. It's a very tough material but very lightweight material, and it can withstand high pressures. So that's the reason why carbon alloy has been used for using the valve making. So these mechanical valves, the way they work is they have hinges, like we have hinges in the for the doors. So the current model of valves that we have are called bi-leaflet valves because they have got two doors. Earlier we used to have single leaflet valves which used to open and close like toilet seats, but those are previous generation. We don't use them any longer. The present generation of valves are called bi-leaflet valves. So they open and close like doors, and they have hinges. Now the problem comes with these hinges. Because they have got hinges, and hinges usually need oiling for the smooth functioning of the doors, but we cannot obviously put an oil inside the heart when the patient is alive and the valves are placed inside the chamber of the heart. That's the reason why what we do is we thin the blood of the patient to make it like oil and make sure that the doors are not jammed. In order to thin this blood, we give a tablet called either acetrom or warfarin, which patients should take every day without fail. They can forget about their meals, they can forget about any other medication, but they should not stop taking this acetrom or warfarin every day, because unless and until they take this medicine, blood is not thin enough, and if it is not thin enough and if it becomes thick, then the valve can get jammed, and that can cause a life-threatening situation which can kill the patient within a few hours. So it is very important that when a patient gets a mechanical valve, they should be on lifelong acetrom treatment, and they should never ever stop the treatment. Also, person to person, the dosage of acetrom and warfarin varies. Many tablets like paracetamol, we don't think about how much dose to be given because it's a standardized formulation. So most patients will get 500-600 milligrams of paracetamol, they are fine. Whereas with acetrom, the dose needs to be determined for each patient. It could be 1 milligram for someone, it could be 5 milligrams for someone. So the dose varies. What dose works for that particular patient, we need to work it out. So for the initial 2 to 3 months, you may have to get a blood test done called PT-INR to check whether acetrom is functioning adequately or not. And once you get your right dose, then you can do this test every 2 to 3 months. But again, doing this test and making sure the blood thinning is appropriate is very important. We aim to get a number of INR of between 2.0 to 3.0. What this means is that if the INR is 2.0, that means the patient's blood is thinned double the time. So if someone is taking 13 seconds to clot their blood, patient's blood will take 26 seconds. So the time has doubled. So they have to be careful to make sure that they don't get injured. So any small injuries can make them bleed for a longer time, and things like accidents and all, they should be having a card saying that they are on acetrom and that can warn the doctors that they could bleed profusely. So we need to take a lot of precautions. Mechanical valves are usually preferred in patients who are less than 60 years. Patients who are more than 60 years, we tend to use a biological valve. Biological valves are taken from animals, either a pig or a cow. We just simply take the valve, wash it with cleaning solutions so that our body does not react with that tissue because we have taken it from a different animal. Once that treatment is done, it is mounted on a plastic mold with cloth around it, allowing for us to stitch it into the heart. Biological valves are good for people who are above 60 years. The advantage with biological valves is that you need not take acetrom. it is almost like a normal valve. But the disadvantage is that they tend to get damaged over a period of time. Because it is a foreign tissue, if you put it in a young patient, within 7 to 10 years, the body will identify that this is a foreign tissue, start depositing calcium on it, and these valves will become hard and they do not function, and maximum they can work for about 7 to 10 years. Whereas if patient is above 60 years, the same valves tend to work for 15 to 20 years because the body's ability to deposit calcium, ability to detect outside tissues will become less, and so the reaction becomes less, so the valve will work for a longer time. So that's the reason why biological valves are preferred in older patients. But with improving technology, both the mechanical valves are getting better, so that your requirement for acetylene and blood thinning is becoming lesser and lesser, and also biological valves are getting better, so you can implant them in younger and younger patients. Apart from these valvular solutions, nowadays we have what is called as a percutaneous valves. These percutaneous valves can be put inside the heart without having to do a open heart surgery. Now, whatever I have told so far are done with open heart surgery. I will come to that in a moment. In percutaneous valves, they are done like an angiogram. So they from the groin, one tube is passed and it is placed in the right place where the valve should be, and the valve is what we call as a diploid. We just put the valve there and make it blow up to the right size so that it starts functioning immediately, and it's a quick procedure. At the moment, it is being done in sick patients in whom open surgery is not possible, but the way ahead will be that these valves will become a normal way of treatment in future. At the moment, their cost is also very prohibitive, but that I'm sure will come down with, as time progresses. Now a brief word about how we do the surgery and then what will happen after surgery. The usual way of heart surgery approach for a valve heart disease is through the breastbone. So a cut of about this size is made on the chest, and the bone is cut, and then we have direct access to the heart. This approach is very good for valve repair and valve replacement. Valve repair particularly because you have the heart right in front of you, the valve right in front of you, so even a complex repair, you can do a better job. The other approach is through a keyhole surgery, through right side of the chest, through a small surgery, and then use laparoscopic instruments, cameras and tubes, where we can see a magnified view of the valve and either do a repair or replacement. Now that needs a specialized setup, so the cost of surgery will be higher than the usual. But the advantage is that the scar will not be visible when you wear an ordinary dress. The second thing is the recovery is faster than normal approach. I would say the best approach for any patient should be decided by the surgeon, because what needs to be done inside is the most important thing, and what your surgeon is comfortable is you should be giving that comfort to your surgeon. To be honest, the difference between an open chest and keyhole surgery is not very much when you think about long term. This is only we are talking about the short term in terms of 1 month or 2 months of time for recovery. Whereas in the long term, what really matters is how it is done inside. So to put it in another word, if you have to repair a watch, doing it right in front of you is much easier. Rather than that, put the watch in a box, make a small hole, use long sticks and do the repair. It can be done, it takes longer time, but again, what is important is how the watch is repaired. So leave the decision to your surgeon and let him decide what is the best approach for you. Either ways, the surgery takes usually about 3 to 4 hours, and you would spend a couple of days in the ICU, and after that you come to the ward. Usually 5th to 7th day after surgery you can go home, and at the time of going home, doesn't matter whether it's done keyhole or open surgery, you will be able to do regular activities like walking, going up and down the stairs, going to the toilet, having a shower. All those things can be done, and in fact we encourage you to do as much walking as possible. And usually within a month or two you should be able to recover. But at least for 2 to 3 months, we recommend not to do heavy jobs like driving, lifting weights, lifting children, and things like that. But routine jobs like working on a computer, writing books, reading books, watching television, doing cooking without lifting weights, like making tea, rice, and all those things can be done almost like 2 to 3 weeks after your surgery. So it's not a surgery after which you are bedbound or you will not be fit to do anything or anything like that. No, surgery is much better. So far the evidence has shown that doing a repair of a valve is much better than replacing it. But again, many valves may not be repairable and they only need replacement. So whenever you discuss with the surgeon, have a plan A and plan B. Plan A will be a repair strategy, and if plan A doesn't work, what valve you want to use. And again, as in any other industry, there are a huge spectrum of valves which you can select from basic valves which cost less to advanced valves which cost much higher. So have a discussion with your surgeon, decide what valve you want to have, and based on that you can have a plan B formulated. So hopefully this video has helped you understand what valvular heart disease is, what treatment options we have got, and what precautions you need to take, and how your life will be after surgery. I would make one more video in which I will go about in more detail about the type of valves and acid trauma and what precautions that need to be taken, because some dietary precautions are important when you take acid trauma, but I will discuss those in a different video. So please be on the lookout for that. Thank you.